So I was asked to give a brief overview over targeting DNA repair, and this has become increasingly important for not only treating breast cancer, ovarian cancer, but as we're doing more next generation sequencing testing of both germline and tumor testing, we are seeing that this DNA damage repair or DDR pathway is increasingly important, not only as far as how it affects cancer cells, but has been shown now with multiple trials to be something that is targetable and very effective with different inhibitors. So I think that we have just scratched the surface of where we're going with targeting these pathways. And I lay the groundwork for some of the data looking at patients mostly with germline BRCA1 and 2 mutations, and how different chemotherapies such as platinums have been shown to have more benefit in patients with one of these mutations. And now we have 2 PARP inhibitors, olaparib and talazoparib, that have had phase 3 randomized trials. Both met their primary endpoint of progression-free survival improvement, as well as improvement in quality of life for our patients with metastatic cancer. So PARP inhibitors being really just the first as single agents, but there's so much going on with combinations of PARP inhibitors to either increase how long they are effective or increase the group of patients that might benefit from PARP inhibitors, such as patients who don't have a germline BRCA mutation. And the entirety of this whole session really looks into where we're going with targeting these pathways. So for patients with metastatic cancer, the 2 trials, the OlympiAD trial and the Umbraco Trial, both looked at a single agent PARP inhibitor versus physician's choice of chemotherapy. Both trials showed improvement of progression-free survival, which led to their approvals for use for patients. But what I think is really important about these trials is the significant improvement in quality of life. And it was across the board in both the OlympiAD and the Umbraco trial, showing this is really a class effect. In other words, those patients who were randomized to the PARP inhibitor, not only just because it's an oral agent and not having everything associated with requiring IV infusions, but there was actually an improvement in quality of life compared to those patients who were randomized to physician's choice of chemotherapy, who showed a decrease in their quality of life. As we look at different therapies for our patients with metastatic cancer, I think that these trials really show how to move forward to make sure that patient-reported outcomes and quality of life is every bit as important to be measuring and reporting on, in addition to progression-free survival when we're talking about differences of several months. For patients with metastatic breast cancer, it is hard to show overall survival with many of the trials we do, mostly because many patients have so many different lines of therapy. At AACR earlier this year, we did present the overall survival data from the Umbraco trial that did not meet statistical significance for improvement of overall survival. It is, I think, also important to note that that trial had quite a bit of crossover in the fact that as the trial was ongoing, oral PARP inhibitor did become commercially available, and a large portion of patients did actually go on, who were randomized to physician's choice of chemotherapy, go on to receive either a platinum or PARP inhibitor. So I think looking at totality of not just the improvements and the response rates, which were quite high with PARP inhibitors, the quality of life is also just as important, if not more so.